I'm very pleased to be here, just very thankful for the entire Virtua leadership team for inviting me here today, and of course to all of you as clinicians and frontline caregivers for really wanting to know more about this topic. I want to start by showing you a slide that is going to go through the formal CME language about what this is about. But what really it's about is patience. And what I want to convince you of today is that this is not an alternative extra category therapy. This is supposed to be another tool in your toolbox of therapies that work for conditions that you may encounter every single day. And that's part of my goal here today, to convince you of that. Just a little bit about patient demographics. The number one diagnosis still is intractable skeletal muscular spasticity. And you may find that to be an odd diagnosis to be number one for this condition. But really what that is a surrogate for pain. For patients that previously had pain but had muscular spasticity as a secondary aspect of that pain, that was the diagnosis that was used to give marijuana to them. Now you no longer need to, as a physician, bill it as muscular spasticity or look for it in your clinical exam to be able to offer it to your patients. We now have chronic pain as its own independent condition. You see the second most common condition is chronic pain from musculoskeletal disorders, because that is the fastest growing condition since we added it to the list in March. We also have anxiety close behind that. It is an effective treatment for anxiety, particular strains, especially. That is one of the new conditions. And then we have PTSD, which has been a condition for quite a while now. And then we have other forms of pain shortly after that. By age group, it's an interesting distribution. So the most common age group are the ages between 41 and 60. So middle-aged patients where they're starting to get chronic disease and pain, anxiety, and other conditions secondary to chronic disease. That is the most common, by far, age group of individuals who are benefiting from this therapy, not unlike other therapies that you give based on your patient age distribution. This is not something where you only have younger people who just want to use it as a workaround to legalization. This is obviously data that speaks against that. These are older individuals with chronic conditions that we're treating. We do have younger individuals as well as the second most common, but then we also have seniors. 61 and older is the yellow category on that pie chart, who comprise about a quarter of the patients. And we're seeing more and more of those patients come in because, again, they have more higher incidence of chronic pain and other conditions for which marijuana can be beneficial. And so just wanted to highlight those demographics for you to really communicate the rigor and legitimacy of the program. Demystifying the forms of therapy, I think, is really important. It's important to understand that there are ways to deliver marijuana as a therapy other than the actual flower bud, which is what people typically think about with marijuana, the green, dense, pungent, thing that you see with marijuana. There are many other ways to actually administer it as a therapy. So all patients qualify for oral formulations. So these are now lozenges that you can recommend to a patient now. They dissolve in the mouth and are absorbed by the vasculature in the oral cavity. That's distinct from edibles, because edibles you actually swallow and ingest and it's metabolized through the liver. Unfortunately, for whatever reason, the initial legislation limited edibles to minors. And so what the lozenges do is it allows for a different intake other than smoking or vaping or other ways that you can take the flower, and it actually comes in a formulation that looks like any other medication in a pill bottle, and really starts to work to reduce the stigma around it. We also have topical formulations. So for musculoskeletal pain in particular, that's localized on joints, on different areas of the body, on your skin. We have oils, ointments that actually work locally. And there's, of course, some systemic absorption, just like you see with other topical medications. But mostly the activity is local, and it is targeted for those types of conditions. And then we have the flower, as I mentioned, which can be smoke vaped, or it could be made into oils that can be ingested. And so patients will have preference for how they use the flower for therapeutic reasons. We now also have, for patients that do want to vape, and again, as physicians, we should encourage lozenges or topical formulations over vaping, over smoking. But for folks who want to vape, there's now a standardized way to do that we offer, because we saw that some patients were actually using the topical forms and vaping those, which wasn't desirable because we didn't know what they were getting. So now we actually have a way of delivering the therapy in a reliable manner. And then, as I mentioned, edibles, which can be taken as tablets, capsules, drops, syrups, whatever children can ingest. And obviously, we're trying to expand that to adults, and that will require legislation. These are the two primary active compounds in marijuana: THC and CBD, tetrahydrocannabinol and cannabidiol. THC has particular activity, and it's effective for pain control. It's also effective for increasing appetite, especially in patients with cancer and other conditions that lead to reduced oral intake and have many other therapies. That is the particular compound that gives the quote-unquote high, that alters sensorium. CBD has those effects. It's also particularly beneficial neurologically. It has anti-seizure activity. It works for neurologic conditions such as multiple sclerosis, preferentially, and other neuropathic pain, etiology related to the nervous system. CBD is particularly effective. But it's also effective for pain control, and particularly for patients who do not want their sensorium altered with therapy. There are other ways of classifying the plant types. So there's indica, sativa, and hybrid. That is sort of an antiquated way of classifying marijuana. It's based on the appearance of the plant. Generally, indica strains are more depressive. They cause people to be tired, to relax, may be useful in some patients for anxiety for those reasons. Sativas are more uplifting. They cause a sympathetic nervous system reaction, increased heart rate, a little bit of sweating, etc. And hybrids are combinations. Unfortunately, that's not a very rigorous classification. You do have, variation there, and we've evolved much more the science toward chemotypes, which is a way of classifying based on the active compounds that I just mentioned. So high THC to low CBD ratio strains, and then you have the converse, high CBD to THC. Again, particularly targeted for the condition you're treating. And then you have interim ratios for folks that may have a combination of conditions, for example, that would benefit from both active compounds. And that is really how we communicate types of strains in our modern approach to this. This is the way the lozenges and edibles look. They come in, again, a bottle that looks like just like a prescription bottle that you get from the pharmacy. This obviously leads to the type of behavior you'd want to see in patients. If they put it in their medicine cabinet, they keep it away from their children, and they have the same sort of safety locks as you would for a pill bottle. And again, they allow for a type of ingestion that's not smoking or vaping. These are the way the oils look. So again, similar to other types of oils and ointments used for dermatologic reasons or for other conditions. We have this available in most ATCs now, and again, it's a formulation that could work for localized musculoskeletal pain in particular. And these are the way the ointments look. Again, just like any other ointment, this is where you have the THC and the CBD extracted from the plant, and this all happens, by the way, right in the ATCs here in New Jersey. So I want to review the evidence base with you. Just a caveat saying you may be underwhelmed when I go through this because there isn't enough large-scale research to convince folks that they should be using this as first-line therapy, for example. I will say that there is a reason for that, which is because federal funding is not available for research, and everyone knows that that is the primary source of funding for large-scale rigorous research. And the reason it's not available federally is because it's still a Schedule I drug. And I'll go over that complication in a little bit. The first study I like to mention is one that is a randomized clinical trial for pain control. It goes through, it's a pragmatic consideration of a number of trials in the use of cannabis for pain control. and it's the closest thing we have to a meta-analysis for its effectiveness for pain. So 56 hits were generated from the trials that they looked at, about 38 randomized controlled trials in particular. The key result here is that 71% of the studies concluded that cannabinoids had a demonstrable, statistically significant pain-relieving effects. So this is probably the best study that we have for pain control, and about 29% did not show that. This is a particular study for HIV/AIDS, in particular for intake, mood, and sleep. They looked at both dronabinol and smoked marijuana in HIV-positive marijuana smokers. And they looked at the results against placebo, which was basically nothing. And so when they took it, they noticed an increased sleep time that was not statistically significant, but at least perceived sleep time was better. But very importantly, appetite was statistically improved in patients receiving marijuana therapies versus control. This actually looks at neuropathic pain in patients with HIV/AIDS. This, by the way, has been a condition that you could prescribe marijuana for a number of years now. So this was a randomized controlled trial, smoke either cannabis or an identical placebo cigarette. So people were actually smoking in both arms, which is interesting. So the smoked cannabis reduced daily pain comparatively by 34%. So this is a pretty strong trial. And what's interesting is that for the usual drugs that we give for neuropathic pain, like Neurontin, the effects were comparable. This wasn't a direct comparison to Neurontin, but about 34% reduction in measured pain, self-reported pain in patients taking marijuana. For rheumatoid arthritis, you'll see this is a pattern for a number of inflammatory conditions. This was a study that looked at the efficacy, tolerability, and safety of cannabis-based medicine, in particular Sativex, in the treatment of pain caused by RA. And so this was actually the first randomized controlled trial looking at rheumatoid arthritis as a condition. And the way it was designed was whole plant extracts that were delivered in equal amounts of THC and CBD. So this was like an interim chemotype compared with placebo for 5 weeks. So 2 arms. The DAS-28, a standard measure of disease activity in rheumatoid arthritis, showed a statistically significant improvement for patients receiving marijuana therapy over control, recommended larger scale research. And you'll see that as a pattern with many of the studies, recommending bigger studies that aren't possible because of the lack of funding. Another inflammatory condition, this is for IBD, the impact of cannabis, not just on objective symptoms, like weight and clinical disease activity, but also quality of life. And it was a single-arm, 13 patients with long-standing IBD that was difficult to control, prescribed cannabis, and they looked at 2 quality of life questionnaires as outcomes. And so after 3 months of treatment, really improvement across the board in health, social functioning, ability to work, physical pain based on survey, and also an objective weight gain of 4.3 kilos during treatment, which is pretty remarkable. This study looked at medical marijuana's effect on epilepsy, and as I mentioned, high CBD is particularly effective. 213 patients, open label access study for a treatment-resistant epileptic condition, such as Lennox-Gastaut and the other seizure disorders. All patients were prescribed cannabidiol, liquid daily dose, gradually increased to a certain dose over 12 weeks. And 137 patients completed the study, and the number of seizures decreased by an average of 54% in a group of patients that were refractory to prescription drugs for seizure control. So clearly effective, in particular CBD. This is looking at multiple sclerosis. Seizure disorders and MS are approved conditions in New Jersey. This one was a 19-week double-blind randomized placebo-controlled trial, pretty well designed and executed. They were treated with Nabaximols as an add-on therapy in addition to, that's what Sativex is, it's a type of Nabaximol. And 272 patients received greater than 20% measured improvement in MS symptoms with standard disease activity measurement batteries after 4 weeks. And so the study was important not just because it showed effectiveness for MS, but also because it started to identify the standards for good studies to execute going forward, in particular for neurologic conditions. This is a study that is an epidemiologic assessment of the association of medical marijuana with reduced need of prescribed opioids for pain control. We have two studies, landmark studies, that were actually published in JAMA this year, earlier this year. And one of them looked at the Medicaid population, and one of them looked at the Medicare Part D population. So this particular study looked at Medicaid, looked at 5 years of data, and this looked at states who had implemented medical marijuana laws versus states that did not, and found that approximately 6% lower rate of opioid prescribing in those states that have medical marijuana programs. So clearly, the potential of offering medical marijuana as a therapy reduces the need and leads to reduction of opioid prescriptions, which we know downstream is a risk for addiction and adverse outcomes. This is the study that looked at Medicare Part D patients. The endpoint they looked at wasn't prescribing, it was total daily doses of opioids prescribed. And so states with active medical marijuana dispensaries had almost 4 million fewer daily doses filled of opioids. Again, demonstrating that medical marijuana programs lead to less opioid prescribing. And both of these studies supported this study, which was actually published a number of years ago, that associated states with medical marijuana programs with actually a lower opioid overdose mortality. And before, you couldn't really say from a confounding standpoint whether that was due to the availability of medical marijuana. But of course, those two large epidemiologic studies I just mentioned support the potential causal relationship with the availability of marijuana and the reduced reliance on opioids. And what this graph shows actually is that it's not just a binary state of having it versus not. Expansion and development of medical marijuana programs lead to a greater reduction in the use of opioids and reduction in death from opioids, and that is a major reason why we are expanding the availability of marijuana in New Jersey. And so all of this was synthesized by the National Academy of Medicine last year in a landmark report that they published on medical marijuana. They had been solicited for guidance and information from clinicians across the country, and the National Academy decided to take a comprehensive look at the scientific evidence and assessment of the research quality and what the gaps were in research and recommended improvements and how we can better elucidate its benefits in patients. And so the major recommendation that we've taken to heart here in New Jersey is that the research has been inadequate. There are major research gaps, and the way to fill that is with effective partnerships between public agencies, philanthropic organizations, and academic medical research groups, which is a major reason why I'm here speaking with you today, virtue of being an academic medical center where we have the potential to do research together, hoping that we can get funding to do that. It also recommended, of course, improving the quality of research. That does go with resourcing, but also getting together as professional societies, clinician researchers to figure out how we can set better standards for the research. Surveillance capacity. So just like you have phase 4 clinical trials, phase 4 epidemiologic assessments of prescription drugs, we need the same sort of surveillance for medical marijuana to better elucidate its benefits, but also its risks over time. Right now, it's hard to actually generate a list of clear contraindications, for example, because of the lack of surveillance, and we need to improve that. And we also need to address the major research barrier, which is the DEA Schedule I classification. Part of the Schedule I definition is that there is no therapeutic benefit to marijuana, which we know is not true. That is a misnomer. We know that we have seen these benefits. We have research demonstrating its medical benefits that I just mentioned. So clearly that is an antiquated classification that needs to change. And so we have the New Jersey delegation that's been out front, particularly Senator Booker, who's been saying we need to get the DEA to deschedule it. We've been advocating from our department, as is the governor and the rest of the state, to really change that. Because once that is changed, NIH money is possible, submitting it to the FDA as particular strains to the FDA for particular conditions are possible, and us be able to give better guidance on what strains work for particular conditions will improve. And of course, physician adoption will be much greater when you have a stronger evidence base. They also recommended developing a minimum data set for surveillance. We're starting to do that at the Department of Health. We have an initiative called the Integrated Public Health Database that we're collaborating with Rutgers on. This was a piece of legislation passed recently that really allows for data commingling at the state level on individuals, de-identifying that and correlating it with public health outcomes from a research standpoint. To be able to add our pretty rigorous data set on what patients are getting and how much they're getting at each dispensary to that public health database would be particularly helpful, because we can start to do the surveillance that they recommend in ways that we haven't seen yet. And we think we'll have the capacity to do that in New Jersey with the right resourcing and support. It also recommended uniform terminology for clinical and cannabis research, and also the strains themselves. Right now, we're faced with names of strains like AC/DC and Green Jedi and things like that. And so to be able to write that on a script, or you don't feel as great doing that as a physician. We want to make sure that there's a standard for us to actually be able to rigorously classify what we're giving to our patients. And then standardized and evidence-based question banks as well. Again, will help with the research and surveillance piece of what we're trying to accomplish. So I will go through the known short-term side effects. Again, this is not going to be similar to the level of detail you're used to seeing for prescription drugs, again, because they have large studies that will give you the frequency, it'll give you the exact sort of patient populations that are at risk. What we have now is basically observed anecdotes over time, and we need to improve that. But I just want to make sure that you know the comparison between existing prescription drugs that we've been offering patients for a very long time. Marijuana can cause sedation, impaired short-term memory, impaired motor coordination, altered judgment, and paranoia. Most of those come, again, with the THC-heavy strains, although you do get some of it with the CBD as well. Let's compare that to benzos. Also sedation, dizziness, weakness, unsteadiness, loss of orientation, confusion, particular risks with the elderly and falls, as we all know, and a risk in general for particular patient populations in terms of addiction and withdrawal. Opioids, similar, sedation, dizziness, debilitating constipation, respiratory depression, overdose and death. All of that can happen in the short term. And steroids, which we use for inflammatory conditions, obviously, fluid retention, high blood pressure, mood, memory, and behavioral changes, weight gain, insomnia, blurred vision. These are side effects that we tolerate for therapeutic benefit in 3 drugs that aren't nearly as controversial as marijuana. But again, pretty similar, if not worse, profile for these drugs. And again, used for the same conditions. Effects of long-term use. There's some evidence that there's an association, a slightly increased risk of psychoses like schizophrenia basically for people who use daily marijuana recreationally, which is not necessarily what you would be doing for your patients. An increased risk of social anxiety disorder, potential long-lasting cognitive deficits, particularly in memory, and an increased risk of bronchitis, in particular for patients or people who smoke. For benzodiazepines, cognitive impairment, adverse effects on sleep. I mentioned the increased risk of fall, fracture, depression, and severe withdrawal after only a month of use. Marijuana withdrawal, very minimal, arguably is hard to classify and characterize versus the withdrawal you see from benzos and opioids. I mentioned many of the side effects for opioids. Important here, increased risk of overdose, 2 in 1,000, risk of death. Depression, increased risk of fall and fracture, and 87% increase in all-cause mortality. Does anybody know how many people have died from a marijuana overdose documented? 0. There has not been a single case report of an overdose death from marijuana. And now we have years and years of this being recommended as a therapy, and of course a much longer history of recreational use, and there has not been a single death from the actual marijuana itself. There have been deaths from people impaired while driving who get into car accidents. And so obviously, from a public health standpoint, we have to make sure that the risks of that are well communicated. But again, those risks are there for benzos, they're there for opioids, and they're there for steroids. Cataracts, high blood sugar, increased risk of infection, thinning bones. We all know the long-term side effects of steroids. And then this gets to the withdrawal and overdose data. In particular, for those that believe marijuana withdrawal exists and have documented it, it's about 9% risk for people who, again, are on heavy doses. The severity is, if anything, minor. Some disturbed sleep, decreased appetite, dysphoria, and then that is just not to be compared with both the withdrawal and overdose risks for benzos and opioids. There are notable risks to cannabis use that are documented and supported by epidemiologic studies. The risks for children and pregnant women are notable. We currently do not recommend its use for pregnant women because of potential lasting effects on fetal development. And the same goes for children with rapid brain development and neurologic development. There's a high threshold for its use. And obviously in Jake's case, he had terminal cancer. The benefits outweighed the risks. And for pregnant women, we really don't know yet its risks on fetal development, which is why we currently don't recommend it. I will say broadly that knowing that the risk profile is much less than many other drugs for which we don't necessarily even have phase 3 randomized controlled trials supporting its use, the threshold for its use in adults, particularly for pain control and many of the severe conditions, should be a lot lower. We know that the side effects and the deficits that have been documented are much less than some of the other drugs that we use for the same conditions. And so while we may not have the level of research in terms of randomized studies to directly support its use for particular conditions, we know that the risk-benefit profile is probably in favor of its safe use for many conditions. And so to exercise that judgment as clinicians is what I'm asking you to do, knowing how much benefit it can offer so many people. And so I mentioned the Schedule I research barrier, and the extension of that is, of course, the lack of funding and the lack of data sets. There's also a fear of federal law enforcement. Research institutions and hospitals are concerned about its use because they feel like the FBI can come and raid them. I will say that the risk for that, especially for medicinal use, is quite low. The posture of even the current administration on this has been to allow states to exercise their own jurisdiction on this matter, especially for medicinal use. And so the risk of federal crackdown on this is extremely, extremely low. And I've had discussions myself about this, brief ones in Washington, and that's what they're saying. This is something that's to be left to the states, particularly for medicinal use. We are pursuing and looking into regulatory scheduling changes with the Attorney General at the state level. Again, won't solve most of the issue, which is the federal classification. That's something that could be helpful. A connection with the New Jersey Health Information Network of the recommendation of cannabis, how much and when patients are getting the therapy, as part of a broader collection and network of electronic health record data that the state is building as a public good for interoperability and seamless information sharing. That potential is huge for public health to be able to do surveillance and research. And then, of course, collaboration with institutions like this one for better research when we get the resources and we have guidance on how we can execute research safely and minimizing the risk of federal enforcement. An interesting opportunity has been the study of something called terpenes. It is a particular component of cannabis that is thought to have therapeutic effects even beyond, or at least explaining in more detail what we know about THC and CBD. That is an area of research that is basic science, has a lot of basic science interest, and it's something that we want to explore as well here in New Jersey for people who are interested. I want to make sure I communicate the accomplishments we've been able to achieve after the governor asked me and the Department of Health to audit the program and expand its use responsibly. So the sixth executive order the governor signed was on this topic, shows how important this issue has been to many of his constituents. He's heard directly from so many people, patients that didn't have the therapy available to them now do, and it's among the top issues he continues to hear about in terms of its impact on people's lives. We had a 60-day timeline to do a thorough audit of the program, and we issued a report to the governor on March 23rd. We recommended immediate regulatory and statutory actions in order of the time taken to execute them. In terms of the immediate improvements, we expanded the number of conditions. We reduced fees for people to be able to obtain the card, which certifies you as a patient. That should protect you in all circumstances. If you, let's say, are stopped in a traffic situation by a police officer and they notice that you have a bag of marijuana, if you have that card, it protects you from enforcement. It also, of course, allows you to get the therapy when you're at ATCs. That card used to cost $200 for certain groups. We reduced it for veterans in particular and other groups to $20. Physician names are optional in terms of their publication. So we've heard from some physicians who said, I'd rather not have my name out there as a quote-unquote marijuana physician, but I just want to be able to recommend it as a therapy, which is encouraging. I will say, though, that the majority of physicians still want to actually be published to let patients know that they are physicians who can recommend it. And so I think, clearly that's a sign that the stigma may be reducing. We're allowed more ATC satellites. So these are particular types, extensions of existing dispensaries that do one of the three aspects of the marijuana value chain. So growth, cultivation, and dispensing to patients. And so if they have a growth, they do, of course, have growth capability in their central site if they want to dispense it at another site where they know there's a number of patients who are hard to serve. At their original site, we've allowed for ATC applications. We're processing them now. And we now allow 2 caregivers per patient instead of just 1. Again, a way that we immediately were able to expand access and make it easier for patients. We've also put out an application for 6 more dispensaries. As I mentioned, we have 146 applications that Jeff's team and the committee that he assembled are in the middle of the throes of evaluating now. These are hundreds of pages long, and so we hope to announce as soon as possible who those winners will be. It's a competitive process, and we're excited because this is an important way we're expanding supply for patients. Again, that list is ever growing. And doctors, again, no longer to be listed publicly if they don't want to. We're also looking for a way to give provisional caregiver status, particularly for patients who are terminal, so that they can be classified and given a card quickly to be able to pick up the therapy. We've expanded the product, as I mentioned, to vapable products. We now have mobile access. People can access it on their smartphones. A lot of folks actually from lower socioeconomic status often have only access to their internet from their phones. So this is another way to increase access. And revising the rules that will enshrine all of this permanently. We're reviewing the comments now, and we hope to finalize those regulations soon. And those regulations include streamlining the process for new conditions. So before, we had to get the Medical Marijuana Review Panel petitioned, and they had to go through a particular set of meetings and processes that, of course, extended the time required to approve new conditions. Now we propose that, especially for when a need is identified as more urgent, the Commissioner of Health can actually just add a condition without necessarily having to go through that. That being said, the Medical Marijuana Review Panel is a very important body of physicians and clinicians and other types of stakeholders who recommend conditions responsibly, also will advise us on research. So still a very important body that we will continue to consult. Separate endorsements now for new dispensaries, so just dispensing, just processing, and just cultivating. This will make the market hopefully more efficient and allow for folks, even with less capital, to be able to get into the market and to increase the supply. We think this will not only increase supply, but also price at the point of care, which is an issue for a lot of patients. And that's one major way we want to do that. Eliminating the 10% THC limit, that was an arbitrary limit for whatever reasons that was passed in the original legislation authorizing medical marijuana. And I always bring up Jake's case again for this last bullet point, eliminating psychiatrist evaluation for minors. You're most likely going to be prescribing medical marijuana for children if they are terminal or if they have a severe medical condition. And to have to wait 6 weeks, 6 months in some cases for a child psychiatrist appointment in New Jersey just to be able to do that doesn't make sense. And so it's not that we don't want rigorous evaluation. Again, the only about 0.5% of our total patient population are children, by the way. We still want people to be very judicious before they recommend it to minors. But once they do, once there's a responsible determination clinically that a patient can benefit, we don't want to have that barrier in place. And we're seeing encouraging legislation for the statutory changes we want to see, allowing edible forms, allowing patients to access more than one ATC. These are things that just make sense, that for whatever reason were limited in the initial legislation. Allowing marijuana as a first-line treatment for all qualifying conditions, having a 2 ounce per month limit for terminal patients doesn't make sense. We're asking for that to be eliminated for obvious reasons. Raising the limit over time for all others and make sure we're keeping track with overall supply. And then removing nonprofit requirement for original ATCs to allow more folks to get into the market and to increase supply as needed for the growing patient population. We're also looking into other considerations. This is not exactly planned yet, but we're evaluating the implications. We want to make sure that the patient and physician portal is just more friendly and easier to use. We're looking into home delivery. We have home delivery of mail delivery prescription drugs. Fair question is, why don't we have it for medical marijuana? Well, there are complicated intersections with law enforcement that we need to look into without authorizing legislation. That's difficult, so we have to look into how that could work. External labs for quality control. Right now, we have very rigorous testing of the quality and the strain content with our state lab, and we intend to look into see how we can do that with other labs when the supply increases substantially. Elimination of the sales tax is something we're looking into. That just increases the price at the point of care for patients who need it. And then reviewing the ATC permitting and background check process to make sure that while it's rigorous, we want to make sure that it's as efficient as possible to get more supply in where needed. Just to go through the requirements and eligibility for physicians to get into the program, just 3 requirements to be eligible. A New Jersey medical license, I just got mine a couple months ago. Controlled dangerous substance license, and you have to practice within the state of New Jersey. That's it. You don't have to have any formal certifications. You don't have to go through a training course, although of course it's good to educate yourself as this is the first step in doing so about how this works. But just so you know, those are the only 3 things you need to be a physician in the program. For patients, they have to be New Jersey residents. They have to prove that they have a bona fide relationship with the physician, and they have to have one of the approved qualifying medical conditions. You may be asking why, if you think this is a therapy that physicians should be able to prescribe and recommend, why are you limiting it to certain conditions? Well, good question. In principle, that should be physician's choice, because it is for every other prescription drug. Even though it was approved for a particular condition by the FDA, you can use your judgment and research as it develops to do for non-FDA approved conditions. It's a good question. I think I agree with you, but we have to make sure that we're tracking supply with demand and making sure that until we have better research, we have a program that's rigorous and is at least as matching as much as possible where the research is. So I agree with that sentiment. We want to make sure, at least for the time being, you have a qualifying medical condition while we work those issues out. Okay, so definition of a bona fide relationship. We get this question a lot. The first 2 definitions here are ridiculous, so I'm only going to go to the third one, which is to say that a physician, after a thorough medical history and physical exam, assumes the responsibility for providing management and care of the patient's medical condition, just like you do for every other patient you see, for every other condition, for every other therapy that you recommend. The first 2 have to do with seeing the patient for a year, a particular number of visits. Again, we don't have those restrictions for any other therapy. Why would it be in place for this one? And so that's all you have to do. And really, a clinical note, an HPI, a consult note is all you would need for this to be the case. Qualifying conditions, as I mentioned, a lot for the conditions that I mentioned that there's research for: terminal cancer, muscular dystrophy, IBD, the cascade of inflammatory conditions, neurologic conditions, seizure disorder. These are the new qualifying medical conditions that we added: chronic pain from both musculoskeletal and visceral origin, migraine, anxiety, and Tourette's syndrome. And so this is the latest picture of just the new patients with new conditions. And you see that chronic pain from musculoskeletal origin is by far number one, then closely followed by anxiety, and then migraine, and then visceral pain is shortly after that. Tourette's is a small component, but an important, interesting condition for which medical marijuana has been shown to work. The use for medical marijuana for opioid use disorder itself, not necessarily secondary to pain, is something that we're looking into. So we're in contact with the Medical Marijuana Review Panel. We'll be meeting with them soon for a decision on whether to actually have it recommended as a condition for opioid use disorder itself. Again, separate from pain. You've always been able to do it for people with chronic pain who are addicted. The way that we're likely going to execute this is to say that somebody has to be on medication-assisted treatment as part of a broader evidence-based behavioral therapy wraparound treatment, and then medical marijuana would be used as an adjunct or a supplement to that to help them get off of opioids as a recreational or illicit use. And so that is likely how we're going to end up. We still have to meet with the Medical Marijuana Review Panel and more on that soon. And so we were petitioned in September initially of 2016. And so it's high time we actually give it serious consideration, and the review panel will consider it. And this is our very experienced list of people on the review panel. If you're interested in participating or contributing in some way, let us know, particularly if you have experience or research into this. But we're very proud of the review panel, and Dr. Becker in particular as the chairperson who leads it. This is the form required to register into the program. It takes about 4 to 5 minutes to fill out, and then you're done. It takes even less time if you have your medical license in front of you, because it asks for your CDS number and your license number. And then once you hit the submit button, you're in the program. That's all it takes. And so we will display the URL at the end of this presentation. If you're convinced that you at least want to explore it as a treatment option for your patients, please do register. Again, it's very seamless, and you can do it right on our website after this, even during my lecture if you want. Delivering a safe product is really important, and this is something that we get asked a lot of questions about. We have a state lab that does rigorous testing from our public health component. We also share the lab with the Department of Agriculture. We test every strain that's grown for a cannabinoid profile, metals, and pesticides, also mold and other contaminants. This is one of the major reasons that you can tell your patients it is more beneficial for you to see me and to get marijuana from an ATC versus buying it on the street or illegally to treat your condition. Unfortunately, that's what patients were doing in Maryland when I was there in my residency treating cancer patients. So many of them would come say, look, I don't need this opioid prescription for my pain, I'm on marijuana. I was like, how do you get it? Well, I have a Connect, right? They don't know what they're getting. What they were getting seemed to be working for them. But of course, you don't know what these things are laced with these days. There's a lot of risk with illegal use. And to have a rigorously tested, available product that's pure, the strain, the therapeutic profile, the chemotype, and you know that it's been tested for contaminants is really important to be able to say. And so this is just an example of the array of strains available. Again, various chemotypes, indica, sativa, et cetera, offered currently at the 6 ATCs that we have. And then finally, some guidance on dosing. So as I mentioned, oral administration is first, then vaporizing, then smoking. For oral administration, really try to limit it initially to under 5 milligrams per dose, particularly for high THC to CBD strains, because if For folks who want to limit impairment, you should actually go half of that, 2.5 milligrams, and the standard dose is between 5 to 10 milligrams, ultimately. Oral administration, so people who are ingesting, and this will be more relevant when adults can be prescribed edibles, can take over 2 hours to take effect. And so where you have marijuana toxicity, quote unquote overdose, in states that have recreational marijuana in particular, it's because people eat a brownie and, hey, it's not working after 45 minutes. They eat another brownie, hey, it hasn't worked yet. And then an hour and a half later, they're in the fetal position being dragged into the emergency room. Now, what's interesting is I've spoken to some colleagues in Colorado. There's actually an overdose cocktail that is given to patients who are overdosed. They come in, dark room, a sandwich, a bottle of water, and a television, 2 to 3 hours, they leave the emergency room, they're fine. So that's the antidote for marijuana overdose. Advising new patients to wait at least 2 hours, again, if they're taking edibles. For vaporization and smoking, recommend they start with no more than 2 or 3 inhalations, one at a time. Wait a few minutes in between because it can really cause a coughing fit, which can be really bad for some patients. And again, really rely on high CBD to THC ratio strains for patients who want to limit the psychoactive effects. Thank you. I'm happy to take questions if there's time. Thank you very much.